Oh,
Yeah. Okay, we're back live. Okay,
Good check.
all right, thank you. So we're back.
the question was about the
Yeah.
grants.
Yeah.
So organizations didn't have to apply for grants. We did request that each organization provide a transition plan as part of the granting process. So there were specific milestones that we asked about. Like we are building a document repository, so uploading documents so that we have a centralized place for case management organizations, the state and direct service providers to be able to access documents related to individuals engaged in services is part of the process. That is, as you can imagine, since we have never had that before in our system, a pretty time-intensive project that we've been working with organizations around. We expected that part of the funding might be used to help support individuals with that. We've seen that in there. Is that paying for overtime or bonuses related to achieving that goal? So that is part of what we were asking for as a deliverable within those grants, but grants did not have to be applied for, if you will. They were available to all organizations. And so we've been working to get those. I think we're getting close to being able to make our first payments for organizations related to that.
Other questions? Go ahead, Representative Bishop.
I apologize if this query seems a bit insensitive to the work that's gone into this, because there's been a tremendous amount of work, and I'm coming at this with fresh, inexperienced eyes. But I look out and I see a process going back to the advisory committee work that started in February of 2023, a 2-year plus process that's gotten us to this date. And now the enrollment process seems rather condensed.
Okay, I want to be clear on that because this is a much longer process than 2023. We're just updating because we've made presentations over the years.
Yeah. And so I value all that work to get us to a place where it's going to be launching successfully. But with respect to the individuals involved, the enrollment process seems a little condensed in the scheme of that larger timeline. And related to that, so any thoughts on that? And then related to that, I see there's the auto enrollment if there hasn't been a meeting or a selection. Is there an opportunity to make a change after the auto enrollment?
Yeah, I should have mentioned that. I apologize. So yes, at any time you can request a change of your direct case manager. So if you're enrolled with the Columbus organization and you're working with Dylan and you're like, Dylan's nice, he's too tall for me though. Tired of looking up, it makes my neck hurt. I prefer to work with Jill, she's more my height. You can do that at any time, anytime at all. And there is a process where that you will be able to at any time change Columbus to Benchmark or from Benchmark to Columbus. We are going to initially ask people to hold on that unless there's extenuating circumstances until the first of the year, because we just want to make sure that we have all of our processes around information sharing and that everyone is sort of all like accounted for. Again, if there's extenuating circumstances, we'll work it out, but we want to make sure that our new system is free of bugs. This is a brand new data repository. IT work is tricky, and we want to be sure that we're being really careful with people's privacy at the outset, and we just want to be sure we have all of that worked through. But then once we're past that initial transition period, people will be able to make changes whenever they ask.
The people are signing up. They're doing it.
Yeah.
Signing up online. We can track that.
Yeah.
People who are signing.
Yeah, we are getting strong enrollments.
Mm-hmm.
Representative Steady?
Are people feeling overwhelmed?
Which people?
Clients. Oh, both. Staff and client.
Well, I mean,
How's everybody
or
feeling
everyone
about all
in the
all of
world.
this? I'm sure it must be frustrating for clients.
Well, I think
A
that's
new
the reason
program.
for the around the state meetings, and I think they make a big difference. Those meetings.
Big difference.
Yeah, I will say we've gotten some really positive and strong response from doing those in-person sessions. I mean, the virtual sessions as well, but certainly I do think that the sessions have made a huge difference. So we have had people walk in and been completely overwhelmed, as you
Right.
said. And as they're leaving, come up to us and thank us and say, you know, I feel really good about this now. I really understand what this is. I understand why we're doing this. As you've laid it out, I felt, I didn't think this was something that was a problem. I don't think it's something that's a problem, but I do see why we have to do it. And I think it'll be okay over time. Like, nobody thinks it's gonna be great on October 2nd.
Right.
But people understand that it's something that has to happen and that we're all in it together. We're in it together, the agencies are in it together, and that we're all in it for the people we support.
And I would be remiss if I didn't mention this. Is it more expensive for the taxpayer or more cost friendly to the taxpayer? That's why I was elected. So I always have to ask.
It's Medicaid dollars.
It's expensive.
It's expensive.
It's more expensive.
It's more.
It's adding up.
I wouldn't necessarily say to the taxpayers.
perhaps.
Oh, yeah, the taxpayers payment,
General,
federal.
it's supported by general fund and Medicaid.
And that's taxpayer money.
Yes.
Federally.
All the money's taxpayer.
Yes.
Oh, okay.
Yeah.
I didn't
Wanted
want
to make sure you
for
didn't-
the money.
Yeah, but there's a
There was
difference.
direct payment versus
Right.
Medicaid.
But
So-
okay.
Exactly. And then the Medicaid brings in
Okay.
money to the state.
Okay, thanks.
Representative McGuire.
Thank you.
This goes live on October 1st. The AAA is going to be in the position, both capacity and infrastructure wise, to disseminate all this. That way, individuals that are signing up aren't going to be unserved.
90% have already transitioned. The AAA's already had case management separate from the providers. So that was a process that is practically complete at this point. So to answer your question, yes.
Yeah. How many were needed?
How many case managers
Yeah.
are needed? Angela?
Oh, gosh, I don't have that number available. But I can do some research to see how many additional case managers were hired by the area agencies on aging. We're continuing to work with those agencies around their staffing because some only have a few more to transition when we include the adult family care and flexible choices. And then other areas such as Chittenden County have quite a few individuals. And so they're continuing to hire case managers to support the additional people who are transitioning. But I can get the number of new case managers.
And all of the conflict case managers will be operating out of the AAAs.
Well,
For
anything-
choices for care, not for the brain injury program or developmental disabilities.
Right, so the case management entity for the AAAs is for the Choices for Care program. Just to be clear, that's the case management entity there. For the developmental disabilities and for the brain injury, it's the two case management entities, the independent case management entities that went through the RFP process.
Terrific. Thank you.
Representative Eustis, do you have a question? No, okay, all right. So a couple of questions from me. So appreciate the meet and greet and, getting around the state and that kind of thing. Did the state involve people with disabilities and families in the selection of or interviewing of the providers?
Yes, actually. So as part of our RFP process, we had state staff who did an initial review of the bids that were presented. And then from there, I think there were only 3 that were submitted. Proposals, yeah. So those 3 proposals, those vendors were invited to provide presentations to panels of individuals engaged in services, families, and advocates, although I believe the advocate panel was combined with another panel. But yes, and then those panels had presentations and were offered opportunities to do a question and answer session with the vendors. And then from there, those top candidates were presented to our leadership, and then ultimately the committee that made the choice.
So they provide those panel of individuals provide the feedback back to the
That
state.
was included, yep.
Okay, thank you.
Yeah.
And And then, and I think you answered it. I just wanted to make sure. The slide talked about transition funds to designated specialized service agencies, Benchmark and Columbus, but it didn't say AAAs at the beginning in home health. And I'm just wondering,
They were, yeah.
they also received transition
Yes, they also
funds?
received transition
Okay.
funds. Yes, we didn't spell that out specifically, but yes, they were also offered.
They were further along in the process, so I get that.
Yeah.
And then I don't see on your timeline whether there's going to be a consumer feedback process. So what's the feedback loop post transition, post implementation?
Yeah.
What's the plans for that?
So that is part of our, October and November, our early implementation and stabilization. And then again in December and May in our assessment period and reporting.
So how do you plan to do that?
Yeah, so we'll continue with our, we have opportunities through, we have an advisory committee, we have a steering committee, we have opportunities through the Dale Advisory Board, through the state program, the Developmental Services State Program Standing Committee. We meet with Green Mountain Self Advocates on a monthly basis. We have plenty of opportunities to gather feedback. We are working on a survey to sort of see how things are assessed, like how things are moving along, and are people feeling that their services and their situations are improving post implementation. So we're pulling together a variety of different opportunities so that not only can we connect with people who we regularly have opportunities to discuss and kind of have access to us, but catch a broader group of Vermonters that possibly don't feel that they have avenues to connect with us.
And I realize that there's some, changes happening in the quality improvement, quality assurance process. And so how will that be impacted? And will the AAAs as well as the two new contractors be part of that process now?
Yeah, so I will speak to what developmental disability services and brain injury services will be doing for quality, and then I'll let Angela talk about how the AAAs will have their quality assessed. But so the two contracted case management organizations will have annual quality reviews comparable to the developmental disability services review cycles. And so that's being added into the updated quality services process. But Angela, I'll let you speak about the AAAs.
Yeah, I can say that this year, all of the AAAs will have the quality management team provide on-site surveys and interviews with individuals, and they'll be in that regular process similar to DS.
Thank you. So, you've had to do some work to sort of like untangle the role of the designated specialized service agencies from that of the new case management entities. And I'm just, and it's not part of your slide presentation, but at some point in time, can you get back to us with what is the new definition for how we're defining case management, what that specifically entails, and then the roles that have historically been held by the designated agencies and specialized service agencies? Like, what's the new definition for that? So, for DAs and SSAs, y'all know this, but not everybody around this table knows it. So, the case managers or service coordinators did a variety of different things, from filling in when people were out sick to staff supervision to, all of the things required in the individual support agreement and person-centered planning and all of that. So I know you spent a long time trying to sort of untangle those things. So it would be helpful if you could get back to us with, what those new the roles, right? Like where we're going with that. Thank you.
Website.
It is on the website, but we'll get you a written.
Yeah.
Thank you. Or the link to the website's fine. That's fine. Sometimes it's not easy to find stuff on the website. I'm just wondering, what is the rate being paid? Is it an hourly rate? How is the reimbursement paid?
Yeah, it's a per member per month and it's scaled based on, so we have in developmental disability services, we have 3 levels of need, and then there's like 4 for the brain injury program. So it's a per member per month based on level of acuity. It was included in our request for proposal. It was not negotiated in the contracts. So that is included in the contracts. We can provide that for you. I don't have it memorized yet, but it is a per member per month. And if you convert it back to an hourly, which is what service coordination is now, it is roughly the sort of mid-level is roughly comparable to 2 hours per week of service coordination at the current service coordination rate.
And so, what is the expectation for, number of people on caseload?
Yep, so that's also sort of, there are maximums based on sort of level of acuity as well. So if someone were receiving what we think of now as targeted case management, we have set sort of a higher allowable maximum caseload. If someone had more intensive sets of needs, and a caseload were comprised completely of that, it would be a smaller caseload. Both case management organizations have sort of suggested that they would be unlikely to have a caseload. A case manager had entirely one kind of caseload. I don't love the word caseload, sorry.
Yeah.
But we're supporting people of entirely one level of need. So the average runs about 30 or 35, somewhere between 30 and 35. That sounds very high in our system, but we had been told that the national average runs much higher than that. And we said that we were uncomfortable with having national averages, like running at the national average, which we had been told was closer to 90 to 100. Yeah, thank you. Yes, that's very high. So we're uncomfortable with that. As we heard from both organizations, they're uncomfortable with averages of that high. That doesn't allow for any individualized support. So we were very reassured that both organizations feel that, and anything that kind of is above sort of that 30, 35 is way too high.
And then like right now during this enrollment process that's happening for folks with, in the TBI program and the developmental services, who's explaining their choices to them?
Yeah, so that's right now, that choice counseling, what you're describing is counseling is happening by the state.
Okay,
Yeah.
so
Yeah,
the state employees are doing that?
State employees are doing it, yeah, to get that sort of unbiased choice counseling or referral. Yep.
Yes, we'll get to you in just a minute, Representative Steady. And then is it expected that the case managers will be available to do home visits and meet people in the community?
Love that question. Thank you. Yeah. Yes, we have set in, again, both in RFP and contract, and then again in our case management standards, that visits will happen in the home, in the community. Certainly, we appreciate that this is Vermont, and sometimes in March or mud season, you can't get up somebody's hill or out of your own driveway. But so there is like that flexibility. Sometimes somebody doesn't want you in their space. So, certainly, again, we want this to be a person-centered process, but there are some basic minimum standards around in-person, in-home visits that will need to be achieved.
Thank you. And if you wouldn't mind, if you could send us a copy of each contract, that would be great.
Yep, I can send you copies of the contract. It sounds like maybe you haven't seen our case management standards either, so I'll make sure you.
That would be wonderful. Thank you. Go ahead, Representative Steady.
I guess for myself and maybe other people watching, what was the reason for this move that's more expensive? Was the past practice not working for people?
Are you talking about why we're going to conflict-free case
Yes.
management? It's a requirement by the federal government.
Oh.
We were out of compliance. We have a settlement agreement and a corrective actions.
Well, that's good to know
That's
that it
the
wasn't
driver
our driver.
and not an option.
Okay, that's good to know.
I do want to say that the providers to do a very good job within the current system that they have. And they were not necessarily looking for a change in the system. This is not an option. We have to move to conflict-free case management.
That's really good to know.
I started pretty much every session that I did saying, this is not something I would have cooked up in my little human services.
Okay,
laboratory.
okay, thank you. I think that's good to know for people to know that.
But I have worked in other places where, because as I said, this is the last place. It's been years where it's been implemented elsewhere. So, Vermont pushed it out about as far as it could go. And it's working successfully elsewhere, which is not
That's
a
good.
statement on how it will work here. The statement on how it will work here is that it was very thoughtful. It's comprehensive. It took many, many, many years, very collaboratively, and I'm coming in from outside, so I'm here a year, right? So I see what went into this process to get conflict-free. And conflict-free is necessary because of it's the potential for conflict is a problem, right? It is a serious problem. You can't be the same people who set, let's say, here's how much money I'll make, and then you are the provider who provides the service. Like there's a whole slew that has within it just, conflict, potential, risk for conflict, not necessarily that people were engaging in conflicted activity, but the potential of a system, which is why this system has. This is what your role is independently of this, what your role is independently, and this, what your role is independently is the requirement.
Boy, that's really helpful. And glad I asked, because other people are watching saying, why are we doing this more expensive model? Because we're being forced to.
Well, we are,
And it.
we do need to be in
hopefully will be helpful.
compliance with
Thanks,
CMS.
thanks.
Did you want to add anything to that?
I think that, this is designed for the case management organizations to be complementary to what's happening today,
Good.
right? To come in and to advocate for individuals and families and guardians for what they get today and for what they may need tomorrow.
Perfect. Thank you. That's really helpful.
Okay, so, one of the, that Ms. Garabedian went through and, in terms of talking about the transition process and identifying the best fit within the system and determining the role that best suits their skill set. It's all another way of saying that, yes, the new organizations are recruiting from the existing organizations. That's, it's a fact.
They're recruiting, and yes, people are being hired who currently work at existing organizations.
Yes.
So-
Not unexpected,
Yes,
especially.
yes.
Especially in light of what they are being able to pay people.
Yeah, I just went on their website, amazing.
It's a major problem. I'm just, so you folks who are coming next, so it's a major problem. It's a major problem because we've had lots of conversations in the last week even about payment reform and some of the implications of payment reform for designated and specialized service agencies rely upon the ability to provide services and the penalties that happen or the adjustments or whatever you want to call them that happen if they're not able to provide at a certain level. And certainly the potential and real turnover of staff in these key roles within designated agencies are likely to impact that. And so I guess what I'd say is I'm concerned that there's a sort of a double whammy for existing providers about losing staff. And of course, we know what we hear from families and individuals, not just in the DS system, but in Choices for Care and all around, is the turnover in case managers is like something that is, sort of the bane of everybody's existence because systems have not been able to pay them sufficiently. So I'm a little befuddled about the differences in payment rates and the ability to pay people doing, I'm not even going to say a similar job because it's a different job, but to pay them significantly more than what designated agencies and SSAs are able to pay. But I guess where I'm headed with this is that it feels like something that is happening as a result of this need to change will then also impact negatively providers in payment reform, because they will have lost a chunk of staff that are integral to the service provision, and then they'll be penalized for not being able to provide that service. And so I'm just raising that as a concern and a question for stability of our overall provider system, and something we'll be paying close attention to.
Yeah, we could actually have a conversation about that. I don't know if you want to have that right now. But some of what you're talking about was built into the process because it was done right alongside the provider. So the rates are quite a bit higher. The levels of expectation so that it wouldn't be penalization
Yeah.
were built at based on what the current situation is. And it's a lot of adjustability and flexibility factors within the system in order for it to be able to be more successful. So it's not as black and white.
It's not as black and white. Yeah, no, I recognize it's not black and white at all. There's a lot of moving parts all at the same time, and they do have implications for one another. It's a complicated puzzle, and when one piece is just like slightly ajar, it can affect the whole.
Yeah, I understand that, but also the idea that this is, like a decade in the making allowed for those kinds of things to be thought out, planned out, and built into the process, which is not to say there won't be, challenges along the way. I do believe that there are always challenges when you do a transition. I think some of what was baked in to this system allows for maneuverability around those challenges, whether it's the exceptions process, or the maximum use of flexibility factors, et cetera. So that's why you're seeing certain optimism on the part of the state. But there is, of course, concern that was all along part of the discussion and built in to the processes.
And I'll just acknowledge that the staffing piece is an inherent tension that was and is inevitable, right? We've said all along that a goal here is to ensure that people who are serving individuals in the DD program or the brain injury program, it's going to be a success if they remain serving people in the program, whether it's as a case manager or remaining at a designated agency, specialized services agency, or brain injury program provider. We can't predict or tell people what they want to do with their own choices, other than to try to lay out a transition process that's as thoughtful as possible, as Dr. Bowen said here. And it's tricky too, because if we weren't in a situation where case management organizations coming in weren't hiring staff at designated agencies, we would probably all be having a discussion about why they're hiring people who aren't experienced with our system, who are coming in from out of state. And we don't want that, right? We want them to be knowledgeable in our system, to have been a part of the state of Vermont, to serve individuals here going forward. So it's a conundrum.
Yeah, I mean, I think you raised a good point about that, the last point that you made. I just think that we all need to be aware that this has ripple effects.
Absolutely.
And the ripple effects are not always positive, even with 10 years of planning, that it is, well, not quite 10 years. And there was that COVID time.
20,
Yeah.
you mean a step back?
I just mean,
Yeah.
that it's been fits and starts, and there's been different elements of this that, have, the SIS-A being implemented, and then, the data piece, which came first. And, there are different elements that have been implemented, and, some have been more successful than others. And I suspect that this will be right along with that. We'll learn things as we go through it. And I'm just aware of the fact that when you have something major like this, and then you have payment reform right on top of it, that there are going to be ripple effects. And I don't think that the ripple effect should be less choice for individuals and or less services for individuals. And sometimes because we are not paying sufficient rates for services in some cases, in the past at least, that is, has resulted in us not being able to recruit the people. And we have to think about different ways of providing services, frankly, because
We've begun the conversation.
yeah, there's fewer people in the workforce. And
that's reality across the board. I just want to say something
Yeah.
just to that the effort that is ongoing in the next wave of ongoing efforts is a sit down with each of the providers with the state to go through what their particular projection looks like so that they can see, oh, they're going to be doing pretty well in the new, which many of them will. And some will be doing about the same. Anywhere where it looks like there could be a problem, they will develop a plan, right? So just so you know that what you're raising and, very clearly stated, is something that we have some ability to work with as we sit down on a situation by situation, provider by provider, because there's a lot of variability.
yeah, okay, thank you. Representative Noyes, and then we're going to move to the next group of witnesses. Thank you.
Thank you so much for the presentation today and going over this. A lot of the money that funds this federal mandate is coming from the feds, right? And so with all the changes we're seeing in Medicaid and potential cuts, have you been seeing that they're still going to provide us with those funds through Medicaid?
We haven't seen, so I don't know if people are tracking what dropped on Sunday night from the House, right? I mean, going through that line by line by line and analyzing it and trying to understand it. In that document, right, which is public, and it's, the houses. So then back and forth amongst the House members, back and forth amongst the Senate. Geez, you know how the legislature works. We don't know where it will finally land, but we did not see some of the things in the House version that we thought we would see that were particularly problematic in this space. So we're actually a little bit less concerned than we might have been that this kind of monies will flow. This is the direct service and do not know, again, uncertainties. We're just watching it as it unfolds. But when you ask that question, we can say, we are moving forward. We've got no indication from CMS. Dale has had no concerns with accessing the funds at this time. We don't expect to through the federal 2025 year. We will need to see what the implications are when they land on their final version. So again, we're always going down rabbit hole conjecture until we get the final piece of it. But it doesn't look like some of those cut that would be the kind that you're talking about across the board and necessarily going to be in the mix. So at this point, we move forward, as if a program like this, which is leading to compliance with CMS's mandates, would continue. It's home and community-based services. Ultimately, this is part of our overarching system here. And we didn't see that necessarily, but nothing is really off the table until it's off the table. I don't know if you wanted to add anything to that.
Yeah, I mean, I would say that with respect to the conflict of interest corrective action plan that we have with CMS, our federal partner, they check on that monthly. We give them status updates and no increased scrutiny with the administration change here. It's generally been business as usual with respect to the corrective action plan itself.
And they are clearly expecting this to be stay on track.
I guess, yeah, that would be the thing is like, if the corrective action plan came off the rails, right, what additional scrutiny might come to it, right? the ideal is we won't be having that conversation.
Thank you very much. No, we need to move to the next witness unless says. Go ahead.
I'll try to make a quick question.
Okay.
So with respect to this, the cost question, and this is more expensive to implement than the current plan and largely funds coming from Medicaid, but there is some general fund. Is that additional general fund need going to put pressure on other programs?
It was already part of the governor's budget. It was already included in the governor's budget, so
We just changed the implementation date. They put in for a full year. We changed it to October 1st. We did that here in this committee.
Mhm.
however that ends up rolling out. It was expected, budgeted for, planned for some.
I think it was 6 million, was that
I think it's like 8
8 point something?
8.6 or 8 point, yeah, something of that
So,
magnitude for this year.
but yes, and it's additional cost. I mean, we knew that was going to
I was
happen.
just wondering where it might have created pressures elsewhere within.
Whether any reductions were made to accommodate that, is that your
Yes.
question?
There was none because of its mandated nature. It was on the must-do
Okay.
list, but there are so many things that we would like to do. So,
Well, thank you, Commissioner, and your team. We appreciate you being here this morning and appreciate the update. And we look forward to our continuing updates when we reconvene in January.
Thank you.
so some of us do have to step out, but we'll be able to listen and watch through. I think, Rebecca, you're going to be in the room.
All right, thank you very much. Appreciate it. Next, we're going to be hearing from, I'm not sure who's going first, Rachel or Kelsey, or
We're gonna go together.
you're going to go together? Okay, that's great. Thank you. There's plenty of chairs.
I was gonna ask, should I walk out with the chair?
Yeah, well, we'll take care of putting them back where they go.
She's the chair.
Yeah. All right, thank you. Good morning.
Morning.
Nice to see you and nice to see you again, Kelsey.
It's good to see you.
Kelsey's gonna go first.
Okay. I don't know how many times we've talked about this being a federal mandate, but it's a half a dozen, maybe 2 dozen. Okay. All right, awesome. Thank you, Kelsey.
So just for the record, my name is Kelsey Southseth and I'm the Executive Director at Northeast Human Services and the Co-President of Vermont Care Partners.
Good morning. I'm Rachel, for the record, Rachel Lee, Executive Director of the Counseling Service of Addison County.
And so I think the last time I came, I got to the point a little bit circuitous, so hang with me here, but I want to address a lot of the stuff that Dale has brought up. And the first thing that I want to say is one thing I love about Vermont is that we're here, that we know each other, that we're collaborative, and saying Dale and the Designated Specialized Service Agency have been doing this together. We disagree in a lot of areas, but the collaboration and ability to continue to work together, disagree and come back together, we'll see our colleagues later at our board meeting. So Vermont is a special place like that. And I do think that's also one of the reasons that the services provided to Vermonters here is also frequently some of the highest rated services in the country. I think it's a commitment to the values that we hold dear as Vermonters. So I just want to say we are appreciative of our state partners. So there is a piece here. And so one thing, and so my background, I've my MBA, but with a focus in organizational development. Really, it's underpinning what is the culture, the outcomes that you're trying to build. And
Thank you.
oh, that's okay, yeah. And saying we have to start with and focus on the people who are receiving our services. So that's about our mission, our vision, our values. And so the reason I have this slide, one thing I really appreciate about
HHS's guiding principles is like, these are great words, great statements, but they have to be bolstered by action. And I think the whole part is like, how do we know anybody's better off? They're getting the services that they need and saying, how do we put action to equitable access or providing people with dignity, respect, and independence? Like, we take that really seriously. And so under the umbrella of the state of Vermont, AHS, Dale, like, we have to take it seriously. And I think as the network of DAs and SSAs, we're always trying to put that into practice. And so one of the things I believe, so this is just a framework. I do believe that the case management organizations will be using this as charting the life course framework. And so their core belief fits into our values, which is amazing. So all people have the right to live, love, work, play, and pursue their own life aspirations. And saying like, let's create a framework, our ISAs, our goals under this umbrella, which is great. So we want to have great plans because we need great plans that are influenced by the people who do that. And then we have to implement them. And so I just want to, this is a brief overview, but like the breadth and scope of services that we provide, again, as designated agencies, anybody who comes, we're going to see them as quickly as possible. Sometimes that's hard given that we have to start programs, find physical space, provide nursing oversight, train staff and specialized delegation procedures, which means that we could have a nurse that trains someone who's a layperson, has no technical expertise to change feeding tube or provide intensive medications. We are responsible for that, and we hire direct service professionals, service coordinators to manage the day-to-day services. That can be really intense. And so, like, again, big picture, how do we do this? We've got the strategy, right? So we've got our mission, vision, values. We also have some systems issues. So conflict of interest is a mandate. And I also want to say that Vermont Care Partner organizations are not resisting conflict of interest. We just want to make sure that it's implemented in a way that has the least impact on people who receive services. And so we've highlighted some challenges, and we'll talk a little bit about that in the culture. So it is really important. Jennifer Garabedian said, you know, we want people to like the place where they work and have a good culture. We're really focused on that. We have great benefits, time off. Like, we are focused on that underpinning, saying like, how do we recruit people and retain them? And this comes back to good strategic plans. So this is actually Northeast Kingdom Human Services strategic plan, and just saying like, look, this sets the direction. We included people receive services. This is really staff driven, saying like, the first one is recruit, train, develop, and retain a strong workforce so that other people who receive services are going to be better off. So this comes to, look, this is where it really runs into saying like, how will this actually happen? And so when we're talking about plans, we love good plans, but I've been at many organizations and we hire consultants who make good hourly wages that tell us all the things we should do. They scan the environment. They tell you, here's the market research and all the data, and it's really fancy, and you get it on this nice piece of paper with your logo on top, and then you get it back and then you stuff it on the shelf because you can't actually do the things that are in there because of resources. And so how do you create a realistic strategy that can be implemented? And it is really important to note that strategy has to get paired with implementation. And that is really the crux of what we're trying to get at here, which is we're supportive of the case management organizations. We understand what they're doing. We're going to talk a little about pay. We're not saying they should get paid less, but we are going to talk about the implications of what happens when there's a disconnect or disparity between the strategic planning and the implementation and the people that do that. And so I believe you were asking about this. This is the most up-to-date draft I have about the case management organization. And so Jennifer was referring to this, saying how many people could be on a caseload. And so a case manager caseload size could be 70 people if it was all basic case management, or as you get more intense needs, your caseload comes down. And then you can see the staffing ratios for supervisors. Again, they're trying to keep it low, which we appreciate, but it's more than our current service coordinators hold right now. What's this here? And this is talking about how frequently do people need to see people in person? And one of the best parts about the designated specialized service agencies, which we also refer to as home community-based services, is that we are with people in the community, going to their homes, In the Northeast Kingdom, we booked over 1 million miles transportation. We're projecting 1.3 million miles driven for next fiscal year. And that is getting people in the most rural parts of Vermont to doctor's appointments, to activities, to jobs, because, one of the underpinning goals that we have for folks we serve that have developmental disabilities is like, how do we build their goals, but also make sure people are valued, contributing members of their community. And there's lots of different ways to do that, but you got to get from where you live to where you need to be to participate in your community. And so being available all the time in person, which is what people are asking for, is really important. Again, the case management entity will see folks, but sometimes monthly, sometimes every other month, sometimes quarterly is the only requirement to see somebody in person, which is fine because they have to do it. I think they are going to provide value. To Dylan's point, compliment.
Once a year.
Yeah, sure. Once a year. Yep. Right. Those are the requirements. We hope it's more. They said they're going to try and keep caseloads smaller, but these are the requirements that have been put out there.
I guess there's somebody somewhere that thinks once a year, even for basic case management, is acceptable.
And I think this is what we're talking about, where it's like, how do we comply? And one thing I do want to say, which is hard, but it's saying like, look, compliance is a stick. It doesn't mean people's lives are going to get better. It means we come into compliance to earn dollars that we are trying to apply. But one of the things that is frustrating is that the compliance and regulation is saying in its effort to get rid of fraud, waste, and abuse, which has been a popular term, it creates fraud, waste, and abuse. We have to have experts in data analysis, data management, data scientists, CMOs, psychiatrists on staff, nursing staff to provide good services, but we also have to prove it. And I understand that we should be very careful about how we spend taxpayer dollars. But what it does require is an administrative part of our business, an organization that does take away from direct services. And I would say that coming into compliance is an administrative function that isn't necessarily attached to best practice for supporting people. So I just want to say, like, look, we support this because we have to, not because it's best for people who receive services. And so I just want to, this is the part where it's saying we kind of start a big picture, like what are our guiding principles? What is the strategic plan? This is coming down to saying like, those are great, but only if you can implement them effectively. And this is talking about the strategic versus the tactical. And so what I see here, and I've kind of divvied up saying the case management organization is the strategic part of this important plan, which is going to be meeting with people and saying, what do you want to do? How can we make your life better? Let's chart your life course. Let's get invested. Let's connect you to services. Okay, the tactical becomes the DA SSA network saying, we now have to say, this person has been deemed through the CIS-A to have this level of service. We're going to provide this. Okay, now we need to implement the plan. This plan is great. It's the shiniest plan. It's the best plan we've ever created. Now we have to implement it.
Can I ask you a question,
Yeah.
Kelsey? And I guess I'll ask this for Teresa and Sherry as well, but will the provider, so the designated or specialized service agency that an individual selects, will they be involved in the planning process?
Yes, we should be. It is a little bit delicate. I think those are one of the things we're trying to figure out, like, how does that work? Because the conflict of interest is saying we might be like collateral information is saying, what do you know about this person? But deciding what services and how that's funded is exactly the distance that we're putting. So
Right.
if we're getting weighed in. So yes, the intention is to have collaborative team meetings to talk about what we're seeing and feed it back. But the decision-making will be with the person receiving services and case management entity, not with the DAs or SSAs. We will not be.
Well, not to have an education reference, but it's kind of like the state setting the curriculum standards, and then how that's implemented at the local school district level varies from school district to school district. And I can imagine something similar. So a service plan that's, names all the services that the person's eligible for and is funded for, but then how those are implemented could be very different depending upon the choices that the person and their team makes.
Yeah.
Okay.
And so, I just want to highlight here. So like, this is from that draft. So I pulled the snapshots out in the previous slide, but I just summarized some of the case management duties, but saying, this is listed in that document that will be sent to you from the state. But enrollment, onboarding, redeterminations, assessing and planning, identifying and linking the supports, coordination, monitoring, case management, organization, transfer management. So those are like key duties of case managers. And so again, important, but not doing the work every day with the person. Service coordination duties, we'll talk a little bit about this, but you can see it listed out here. And so one of the key points I want to take is like when you over-index on planning administration and under-resource implementation and direct services, you get unrealistic expectations that lead to frustration. We already had that before this happened. We understand that. Delayed goal completion, lower quality outcomes, ineffective collaboration and communication. And so again, a well-developed plan, if not implemented, is just a document lacking potential to create real change or achieve its intended goals. And for us at NKHS, and I think this is true elsewhere, like service coordinators are like, you're the utility player that you love to have. You play sports, you're like, this person can do everything. Maybe not the best of everybody else, but like they can fill in wherever. They're taking calls after hours. They staff our crisis team because we don't have full-time crisis people. We do it through a pager. They go out to doctor's appointments. They're going out to the home. They're getting calls from SLPs at all hours saying there's a crisis. We need this. I'll follow up tomorrow. I'll see you tomorrow. They're transporting people. So they work closely with the direct service providers, but they are the glue that holds the work together.
So I just want to be clear for members. So would you go back to that previous slide for a moment? The thing that you've outlined is case management essential duties is what the case management organizations, the two new organizations responsibilities are. And then the service coordination essential duties are what DAs and SSAs will continue to do.
Yes.
So that's that clawing out of those.
That's right, right.
Yes.
We talked internally and saying like, this was kind of built in, but the main source of that is saying like, it doesn't feel like things will change that much with the day-to-day that we've got going on, even though these will be taken out. And again, just saying like, this is just a short list of what people are included in service coordinators, but med management. So prescribing meds, making sure we're doing that, tracking that, making sure we're taking them, supporting them at these meetings, nursing support. So yes, we have nurses, but we have a few who do a lot of different work. So again, service coordinators are required to make sure all of this is done well. Behavioral protocols, how do we support this person specifically and make sure they're implemented, train other people on these. Wage reporting, so for employment, make sure Social Security doesn't lapse, because that's a huge issue that we run into that is very time consuming to do. Medicaid, make sure that doesn't lapse. De-escalation, the therapeutic relationship is most important. And Jennifer did touch on that thing. Turnover is killer to anybody who does work with human beings, which is like, it's not plug and play. It's not an app. It's a person you have a relationship with that you've shared your most intimate details that have access to your whole life. All the best and worst parts of it. And just trading someone out every 6 months, 3 years is agonizing and demoralizing and a step back. And so retention is really important to the services that we provide. And then I did name transportation, which is huge, especially in our area. We're doing over 1 million miles, which is an expense, but essential to get people out into their community.
So when people who receive services or their family members or guardians, when they I'm just trying to envision who their main contact point's going to be. So, let's just say somebody has a concern that, their employment services, they want a different job, or they want, they don't think they want to retire. They don't want employment anymore. They want community supports. Who are they going to contact?
I mean, I think that's kind of the crux of the issue. I think what I'd say is like, well, your case manager is supposed to be doing this. And I think over time, to develop a relationship with that person, but there is a bit of that triangulation. So you'll go to them and then they'll talk to us to make it happen. And so what we think will happen, at least initially, is people are going to continue to come to the designated agencies because we're going to be the ones that your DSP is the person that sees you every day for your employment work. And so the relationship, the person that comes out after hours, the person that is supporting you on a regular basis is going to reach out to the person you have a close relationship with. So I think it's meant to be a collaborative effort. Again, as we're just getting underway, I'm not sure. One of the concerns we do have is this is an extra layer. Again, talking about waste, it's an extra layer of adding another person where this was integrated. When we talk about efficiencies, we don't often say, let's separate this, we integrate, because you can have people do multiple jobs. So this does create another layer of saying, I need to talk to this person and make sure to update them because we can't change this now. So they need to do it. And then they need to talk to us and saying, what's it look like on the ground? And then saying, let's come back together, decide, and then say, so that used to be with us. And so there is potential for there's another layer. And anytime you add another person to a communication, it just can it can help, it can take away from it, but more people just creates another opportunity for the telephone game and delay in getting back to people.
Yeah, I mean, which I expect, all of which I expect will happen. I guess I would have, because everybody's different and everybody has different reaction. As you all said, this is the business of human services, including the people who provide them. And what I wouldn't like to see happen is, a family member, guardian, individual, be talking to the people who they're most familiar with, the people that they know now. And then that person says, oh, no, you got to go talk to somebody at Columbus, or you got to go talk to, whoever the case manager is identified. And sort of that telephone tag kind of thing. Hopefully what will happen is that the entities who are being paid, which means the DA and SSA and the case management organization, will take on the brunt of that communication flow, and not be sending people into some sort of circular, telephone tag kind of thing.
And I do think that is one potential thing. We're going to talk about pay in a minute and retention and how important that is. And so one thing over time that, is a fear of ours, but does create some stability, which is the person who's going to be determining your plan may be stabilized because of some of the investments and saying, that's good, that could be long-term. But the thing is saying, and we'll talk about this a little bit, is the same people who did service coordination now, those case managers. So it's like, you knew the person that was going to do it, but now there's a hole. And so the turnover is going to continue to be that issue in the implementation of the good plan and the implementation of people saying, we can get together and talk about what happens, but if you're unable or don't have the resources to do it, you just can't move forward.
Yeah.
And so I do want to emphasize this point. Look, I know it, I understand scarce resources, that is what it is, but there's been this weird response from AHS and Dale saying it's not about pay. You're right. It's not 100% about pay. If you went and you were berated and belittled and people yelled at you all day, like that's a problem and you wouldn't show up to work no matter how much you get paid. Although you get paid enough, people do endure toxic workplaces. We do hear about that frequently. But to say that like there's some structural issue that's going to solve retention that doesn't involve pay is just a myth. Sorry, it is. And saying we're talking about inflation, we're talking about healthcare benefits, like there are structural issues that are going to impact the ability to provide good services to people who deserve them, need them to live fulfilling lives. And the number one thing every single year is pay. And so we're going to talk about the impact of like what bringing in another entity that can pay more for similar experience and skills does, and saying like, you just can't refute the fact that if you don't pay people a competitive, livable wage, they will not stay. They're just going to move on. Okay, that's great. So they stay in the system, that's good. But the implications could be that people in the implementation phase and service delivery just don't have that. So we have a good plan, we don't have great service delivery.
And some might ponder or say that if we had taken that $8+ million and put it into pay, salary, benefits in the existing system, that you might have had an ability for better retention and satisfaction and service provision.
Yeah.
Just saying.
And so well, I agree. But so here, I just want to say like, this is how we've been impacted so far. So we've had 4 service coordinators that have taken positions. We have 3 more who are interviewing. And so, I think this was quick saying, I get a phone call from our DS director saying, hey, someone did this. And then they say how much you get paid. And then they go back and it spreads and saying, great, I can make a lot more money. And so peace, see ya. You can't blame people for taking care of their families. And saying, when you look at it, saying, great, if you double, triple your caseload, of course you can pay people more. I think the ripple effects that you were talking about earlier, saying like, what's the downstream consequence of that when you're saying you're paying people more for, in my opinion, thinking and creating a plan, which is good, you miss out on the implementation again. So what good is a plan if you can't do it? And I just want to highlight saying we have done other programs. Actually, when I testified last time, we're doing 988. We're talking about mobile crisis. Like we have been able to flex and saying really the $23 to $25 an hour is this kind of like magic number, saying like that is enough for people to really saying this is a competitive wage. This is a living wage. This is something that's going to pull me into a field that has good outcomes that I can get behind with my values and want to do it. But it's also the economics of it, saying that has been in our case in the Northeast Kingdom, really the decisive changing thing. So right now our starting wages for DSPs are $18 an hour and service coordinators $21 an hour. And so
They might find people, jumping ship might find that the trade-off of the additional resources, and it depends, it may or may not be sufficient to keep them there, but also having a caseload that's double and sometimes triple what they have been accustomed to having might be not as desirable as they end up thinking it's going to be.
Yeah, and people may come back. I think usually for maybe like, I'm willing to take a couple dollar pay cut, but when you're talking a $10 an hour pay cut, it's not,
That's
I
different.
don't think that will happen, but
Yeah.
maybe. And so, I think just look, no, so we lost 4 people, 13 to 16 clients on our caseload, which again, smaller because you're doing a lot more, you know them more deeply, but that we're talking about 15 to 64 people who've just lost the person that coordinates their services and does that. And then if we lose 3 more, so we can, we're talking about 100.
And isn't that in what
25%.
period? Is that like in
This is gonna last like 2 weeks.
the last 2 weeks?
So-
Just a 2-week
Yeah.
period of time? Yeah,
And and again, pay discrepancy creates imbalance between the planning.
Yeah. okay.
And so again, underway is like, these are just the concerns that we have and worried about saying like goal setting versus outcomes, structural changes to the system of care as potential undermined services. Like, it's really about like, how are people gonna get the services they're entitled to that the CISA and the case management entity and the family and guardians are saying, we want this, why aren't you providing this? Like, this is one of the reasons it's not happening, and saying pay disparities, like payment reform, conflict of interest, saying like, the emphasis on compliance and documentation take away from service implementation and the cost pressure. So, we get a 2%, hear a little bit about that impact, but like, that's health insurance. We're not increasing wages, we're covering health insurance with the increases that we're seeing. So it is this worry and saying, yes, we need to evolve our practices. How can we think differently? But this just has potential. The last thing I'll say is like, one thing that's been hard when we're talking about strategy as an organization is that we have been unable to pivot because we haven't finalized payment reform. And that has been really hard to saying, could we pay people more? Maybe we could have retained people if we knew how payment reform is going to play out. Our fiscal year starts on July 1st. We don't know. We're like Dale said, they're coming out to talk to us about this thing. Like, it's close, but we're saying, how do you pay for nursing? How do you pay for therapy? How do you pay for crisis? Like, always built into this bundle. Well, to your point, if you don't earn the thing from services and encounter data, you don't get the stuff that's not paid for that's considered admin now. And saying like, that is the kind of doom loop that you could run into, saying you have to provide the services to get the auxiliary services that could be more intensive for some people, that you might not draw that down if you're not doing encounter data, which is also a technology hurdle. DSPs, we're using AI to help write notes and stuff like that. Everybody has a tablet, but it's about adoption and behavior change, and saying those are skills that we have to train people in. That is hard when you're just trying to support a person saying, now, how do I log in? How do I do this? How do I do an EMR? How do I do the AI? So we are trying to adopt all the best practices to make sure that the documentation is not the barrier and that people can focus on people. So we are committed to working with Dale, but there are some concerns that are outstanding, and it's coming very quickly, and it's already here. So we have been impacted by law. So Rachel's going to talk a little bit more about what she's seen at her job.
Thanks.
Thank you. And I do just need to do a check on time, because I do want to hear from the 2 new contractors, and we do have 11 o'clock.
Yeah, I'll go quick. So thank you for making time for this. I appreciate it. Appreciate all of the members here. I also want to reiterate, I think the division of the options counseling and assessment from the service delivery is actually a good thing. I worked in the AAA world. We were sort of the early adopters of that with option counseling. It makes sense. It's really about like, how is it being implemented and how are we managing for unintended consequences that are having a severe impact in my agency. I also want to congratulate Benchmark in Columbus, because both Sherry and Teresa are from CSAC, one of the 2 finest leaders in the state. So yes, it is a boon to those 2 organizations. I am so grateful that these 2 are still within the system. I think they're going to do a great job. I never begrudge my staff the opportunity to learn, to grow, to excel, and to move on. We have launched many careers at CSAC, but the timing is unfortunate, and it's happening in an environment where we are increasingly the service delivery is being increasingly hollowed out. And so we're in a vulnerable position, which is unfortunate. So as I mentioned, I've lost 2 of my leaders and 1 lead service coordinator. And it seems like a small number, but it's having a significant impact because we're in a stressed time with a significant amount of change happening for staff. And we also, are building on open positions. So we've struggled to hire in general in our community associates, our DS program. So that's left certainly that day-to-day presence and leadership for our staff. This is hard work. You know, they're constantly trying to juggle, what fire do I put out first? What do I tend to that, you know, first that walks through the door? You know, both Sherry and Teresa did a remarkable job, and my other lead service coordinator have done a remarkable job supporting staff who do hard work. But anyway, other gaps include quality and compliance, supervision, training, support around issues of risk, supporting our residential homes, supporting DHs, supporting families, guardians, the people we serve. You know, I'm doing home inspections, intakes, even though we don't need to do that for a lot longer. I'm left with a gap there. I want to just give a shout out, you know, when this all happened and happened quickly. I also want to mention my program director is on leave, so I'm without a program director. And I had a, you know, oh heck moment, like what do we do? So I reached out to Delana of Champlain Community Associates to help provide some leadership support and a gap analysis to help us figure out like how are we going to manage all this? Because as I said, we've been, you know, really hollowed out in key leadership positions. This is done within the backdrop of extreme stress for my staff. Staff are worried about why everyone is leaving suddenly. I think there's a lot happening. You know, there's conflict of interest case management. There's a significant payment and systems reform. And then you've got the mess at the federal level that we read about and hear about on the news all the time. And for my staff who aren't, you know, in it day to day, it can kind of all smush together and make for a really uncertain time. So people are asking, is the ship sinking? You know, are people, you know, leaving a sinking ship? Are we being taken over? Are we going out of business? There's been an inordinate amount of time spent on soothing people, assuring them that jobs are safe and that we are a healthy and successful agency. This is a blip. We'll get through it. We will survive. It's stressful. We're losing really talented people. It's unfortunate, but we'll get through it. Thank God for my DA and SSA system of care, you know, and the help from CCS and from my colleagues across the system who've been able to, you know, I've been able to reach out to when, you know, when I don't know what to do. You know, people have stood up. I'm astonished by our lack of ability to build bench depth and redundancy. And I think, you know, it's one of the reasons we're in such a vulnerable position. So I thought, you know, we did some research around how we compare to the pay that these two CMOs are offering. I have more reliable data about Benchmark. Columbus didn't. I couldn't find information about their pay. So, looking at starting wage for our DS services director is about $72,000. For the comparable position, I believe is around $116,000 through the CMO. Case managers. We're paying in the range of 45 to 48. We've done some significant investments in CSAC pay in the last 5 years, thanks in part to the legislatures increasing our rates. Case management positions through the CMO is about 62,000. Our program director range is, you know, for persons starting out is in the 75 to 80,000 range. So it's also well under what I believe some of the directors for the CMOs are probably making. And I understand there's active recruiting happening of my staff still. So I expect to lose more people. I think an obvious question is why can't we match the rates of the CMO? Like, you know, we're all getting paid similar rates. Why can't we also pay $20,000 to, you know, $50,000 more? I think Kelsey spoke to that really effectively. You know, DAs provide not just service, but it requires a comprehensive, sophisticated infrastructure to be able to do that. You know, we're responsible for people's lives. And it's not just the delivery, it's 24/7. You know, our service coordinators are on call 24/7. Our house managers are available 24/7. We need to be able to meet people's needs when they arise, and we can't say no. You know, it just has to happen. So there's infrastructure that, you know, that has to be in place to be able to do that effectively, safely, and comprehensively. We have 4 residential homes. We provide, housing for people in the community. So they're living in the least restrictive environment in the community, in the setting of their choice. There's upkeep to that. It's everything from making sure the ramp is safe to, what happens when the toilet gets clogged with an item that doesn't belong in the toilet, or, a refrigerator needs to be replaced, or the lawn needs to be mowed. I mean, those are, that's all, stuff that's coming out of our margin. Home inspections, psychiatry, which supports the entire agency, runs at a loss. Our EMR, coordination with healthcare providers, coordination with families and guardians, and not to mention nursing, quality, and the enormous administrative burden that comes with doing this work. It is out of control. So I know, I've been in front of this committee in the past, and in other committees, we have beaten the drum of inadequate rates. I imagine you are frustrated with me and with us about that. Like, I have heard from our legislators from Madison County, you cannot keep coming to us asking us for increased rates. You have to work with the administration. But what choice do we have when year after year, there are inadequate to no rate increases? And keep in mind, those increases are going are going to my staff. That is the biggest line item in my budget. And I'm proud of that. My job is to create stable, middle-class jobs. I'm not asking you to pay me rates where my staff member can go to a Walt Disney World vacation every year. I'm asking you to compensate us so that our staff don't have to live on public benefits, right? Can take time off to care for family, to rest and recover, can afford to live and play and work in their communities. That's all I'm asking for.
And one thing I just want to add to that, which I meant to speak up here, but like home and community-based services also prevent what happens when people don't get the service we have. They go to the hospital. They're engaged with law enforcement. They're home with caregivers who are fearful that are aging, that they're going to be institutionalized. And so we talk about being stewards of taxpayer dollars. We are preventing people from going to higher levels of care that are more expensive and keeping them in the community and fulfilling the values and the goals that they have. So I forgot to mention that, but it's an important part of what we were just talking about.
Thanks, Kelsey. So we got 2%, enormously grateful. For us, that's probably an additional increase in revenue. Keep in mind, the majority of my budget is Medicaid. About $120,000 for my DS program across the agency, because, we're not siloed. We are siloed, but we're not siloed, right? We have to look across the entire agency. It's about $480,000 to $500,000. I'm budgeting an increase of 10% to my health insurance costs this year. That will eat up $495,000 of my budget that I do not have. So where are the dollars going to come to give my staff a nominal increase to just keep up with inflation, not to mention just affordability? And CSAC employees are already paying 15.75% of the total cost of health care insurance. They're paying a lot. We pay the rest. Employees can expect to see an increase.
The standard these days.
Employees can expect to see an increase in their health insurance contribution. We're waiting on more data to understand what that looks like. I expect my liability insurance to be higher. We under budgeted last year. Despite the 2%, we aren't even close to being balanced to consider an increase to staff.
So Rachel, I'm sorry, but I do need to cut you off. So we understand all of that, okay? And the only reason that the designated provider system gets any increases is because of what happens in this building.
Yes, and
not because of what happens in Waterbury.
Yeah.
Okay, so I'm just gonna say, I think we've heard enough there. I do want to leave time. We've lost some of our witnesses because they had to leave, and I want to make sure that we have time to be introduced at least to the new providers who are coming on board. And the summary of this is that we understand and will be paying attention to a system that's under stress, and that the biggest deal for us is the impact on the individuals who receive services and their family members. And we recognize that has an impact all the way through the system. So when providers are stressed and the people who you employ are stressed and people you contract are stressed, that impacts the services that people receive or don't receive. And likewise, as we welcome these two new two new organizations into the Vermont system, they will experience that as well. They'll experience the ongoing level funding that the state will provide unless they have built-in increases in their contract, which I haven't seen yet. So thank you both for being here this morning. We appreciate it. And I am sorry for the stress that you're going through and the loss of your staff. And I appreciate your attitude that people, need to be able to do what's right for them in their own lives. At the same time, we recognize it will impact people who receive services and your ability to fill those positions on an ongoing basis. So,
What if I could make a final comment? My emphasis on my staff, what I want to end with is it's about people. It's about the people we
Exactly.
serve. So, without good staff, highly paid staff, we're not delivering, top-notch care, which is what Vermonters deserve.
exactly.
Thank you so much.
Thank you.
Thank you.
Thank you both for being here. Okay, so I see we've lost Teresa, but we still have Rick. And it looks like Sherry has rejoined us. So first, welcome. It's a new day for us here in Vermont as we welcome case management organizations into the service system in Vermont. And so I'm going to leave it. I guess I shouldn't leave it up because you're two different organizations. So Carlos, you unmuted first, so you get to go first since you unmuted.
My name is Carlos Hernandez. Again, I'm the Senior Vice President of Care Coordination for Columbus, and certainly recognize that this is no one likes change. We're coming into a new market, and I just want to emphasize that given Rachel's concerns, that we want to work with the providers, recognizing that that we put an importance on the relationship that case managers or existing case managers have with the families that they support. Far be it for me to go in and say, as an organization or just as the culture of our company is to defer to those relationships that have been occurring, to defer to those providers who know the individuals better than we do. And certainly what we will do moving forward, and I'll keep it short to let Benchmark and Sherry, if they want to comment, is to go ahead and say that we're coming in to be complement and kind of be good partners. If we see an area that is being underserved or there are services that aren't available, we'll come in as a national agency to kind of see if we can facilitate those services in those areas or find an outside provider that may want to do business in Vermont. But again, we're not coming in as conquerors. We want to be as partners.
Interesting.
Yeah.
Thank you, Carlos. I'm just going I'm going to, and I don't know if you, either of you have the history of, you're going to be viewed with a healthy dose of skepticism because you are outside of Vermont. I'm just letting you know the bias exists. And I have that personal bias myself. I'm putting that out on the table. And I appreciate the fact that you're coming with open minds. And for us, it's really actually even more important that you have open hearts. So those are the things that we definitely look for. And anyways, Rick, why don't you or Sherry, either one of you, introduce yourselves, and then we'll have just a few minutes for people to maybe ask a few questions.
Yeah,
Sure.
so
Thank you very much. Go ahead, Sherry. Go ahead,
Okay.
Sherry.
Okay, so I just want to say, I missed some of Rachel's comments because I just jumped off there for another call. But I've been working in the field in Vermont for many, many years. So I started working with adults with intellectual and developmental disabilities in 2007. I'm actually coming from CSAC. So one of the things that Columbus has really done is they've allowed me to kind of stay and support CSAC until the end of the fiscal year. So, I mean, that's just another way that we're really kind of working to help bridge that gap.
Thank you, Sherry. Yes, she did mention that she lost two of her best people.
She's working through that.
Yeah. Okay, Rick.
Yeah. So thank you, everybody. Appreciate the opportunity to speak to you. Really quickly, my name is Rick Adams. I'm a vice president here at Benchmark Human Services. I've been in the field for 27 years. 25 of those years, I was involved in residential as well. I've been through what the providers are going through. So I certainly understand that when you have this big a change in the system in any state, it's rough. I mean, there's no way to put it. It's just going to be a little rough for a while, a little scary. I'll echo a little bit of what Carlos said. We're here to work with folks, and I certainly appreciate both Kelsey and Rachel's recognition that Columbus and Benchmark are not coming in and causing a problem and trying to take over the state. They understand we're answering a call of a need for Vermont, and that will make things. It's really refreshing to have providers feel that way, because that will really make this transition go smoother as we work together. I think that's our goal. Our goal is we want the individuals to not really see much in the transition, as little as possible. We don't want their lives to get bumpy. We want to be able to help provide that stabilization. My apologies to CSAC, because yes, Columbus took Sherry. We have Teresa, and she's correct. Teresa's phenomenal. So I will say though that we, several weeks ago, we met with all the providers on a meeting with Dale, and we both put out there, I think I recall Columbus doing this as well, that if you have key folks that tell you they're going to come work for one of us, reach out. We'll work out a system to kind of help ease that pain. If we have to have somebody just part-time for a little bit to help, to do that, then we're more than willing to try to be as flexible as we can. Our goal is to, again, get qualified people, but we know and understand it's a stressor on the system. 2002 as a provider in Indiana, we did residential services and case management, and we were on the residential side. So we understand that stress. So I'll stop talking because there may be questions, and I know you have a heart out, but thank you again.
Thank you. One of the questions, and it won't be for now, obviously just yet, but when we invite you back in January, we'll be interested to know at the different levels of case management that are outlined in the grant, how many people you have at each of those levels. I'm very interested to know how many people that we have at that very, I forget what it's called now, whether that's the one where you only see somebody once a year. That's a concern for me, I'll be honest. And I'm hoping that we don't see very many people in that realm, but I suspect that we will see more than, I'm just trying to figure out how you make it all work financially. So there'll be more people at that level. Therefore you have fewer case managers. So it'll be interesting. So we'll be interested to see the data, to hear about people's experiences. We'll be talking with folks and be following up on this again in January when we reconvene. So for now, we appreciate the introduction, and we will want to hear more about your companies, like what other states you were working in, and what your experiences have been in the first 6 months of implementing here in Vermont. So we thank you very much for being here and sticking with us through the last couple of hours. We appreciate it.
No worries at all. Pleasure.
Thank you. Thank you very much.
Thank you.
Alrighty. Thank you. Okay, committee members, we do have an 11 o'clock testimony, but we're going to take just a brief 10-minute break. And I'm sorry we didn't have a chance to hear from people around the room, but we're going to take this back up in January after there's been a few months of implementation, and we will definitely plan for people with disabilities and family members to be able to speak directly at that point in time, and with advance notice. So I didn't know other people were going to be here. So thank you for being here, and appreciate your time and